me move myself up. All right, so welcome back. Glad to have you for a second week. Really today is focused on diagnosis, management, and intervention. What I wanted to share is every year we provide from the Alzheimer's Association our 2021 facts and figures. So every year new facts and figures came out. And there's a couple of areas that I just really like to bring awareness to everybody. So as you can see here, 1 in 3 seniors will die from Alzheimer's and other dementias. That combining breast cancer and prostate cancer combined, Alzheimer's kills more than breast cancer and prostate cancer. There's more than 6 million people currently living with Alzheimer's disease, but we're projecting by 2050 that that's going to double to more than 12.7 million individuals. And that's why it's really important we get ahead. You know, we're going to be talking about care planning and other tips and tools we can give, but this is why it's so important. And then one area that we're seeing focus a lot more is around what we're finding in discrimination as a barrier to care. And so the Alzheimer's Association has 3 efforts that we are working to improve the current situation. We're hoping to prepare healthcare workers to care for a racially and ethnically diverse population of older adults. We want to increase diversity in dementia care. And we also want to talk about engaging, recruiting, and retaining more diverse populations around Alzheimer's research and clinical trials. So that's really becoming a focal point for us as an organization because we know this affects more people in the African American, Black, and Hispanic Latino population. So as we talk, it's really important around the benefits of early diagnosis and intervention. And we know that the medication, the medical management play an important part around Alzheimer's care. And so if we are getting ahead of this earlier on, we are able to help in reducing and saving cost. We can identify opportunities in lowering hospitalization, recidivism around the emergency room. And again, when we're dealing with Alzheimer's and other related dementias, it really is encompassing of all medical care. And so that is one of the key components of early diagnosis. We'll be providing to all of you resources, and those resources will come in the way of links as well as PDFs. But this just gives you an overview of some of those that we can offer. Our cognitive assessment toolkit, which includes the algorithm. We have a CME that's free on dementia conversations, really about how to have those difficult conversations. I'll be sending that link to you. We also have YouTube videos where we have interaction real time with a patient around doing the cognitive assessments, when somebody's diagnosed, what that care plan looks like, and how to engage. The Alzheimer's Disease Pocket Guide app, I highly recommend that you download. So you'll see that over here in the corner. I'm circling with my mouse. That link will be also given to you. It can be put on your phone or even on your desktop. It has links to our different cognitive assessments that we recommend, but it also has PDFs that you can print out for your patients around the diagnosis and also for resources for the caregivers. When we get to the point of a diagnosis, even in MCI, we encourage really starting that care planning. And so we'll provide that care plan toolkit that goes with that CPT code 99483, which can be done twice a year. We really encourage it even in the early phases, not just of diagnosis, but in an MCI. Are we looking at their ADLs? Do they have their finances in place? Do they need resources if they're a veteran for veteran resources? So that care planning is really important to be done twice a year and is available through that 99483, and I will send the link for all of that. We're doing these short segments, 30 minutes. This is our second one. We have another, but we do encourage people to participate in our Alzheimer's and Dementia Echo program. It's a 12-session, eligible for 12 CEs. We're currently in our springtime Alzheimer's and Dementia Echo. We offer it typically twice a year. It is a time commitment, but we have found increase in confidence with our providers taking the program, also with being able to support caregivers. We see really, as far as testimonials, more confidence in the provider to provide real-time support and decision-making, and has reduced significantly sending to the emergency room. So that's one of the areas that I've seen a lot of positive influence with the echo, and really the confidence of managing not just the patient, but also caregiver expectations. So that's where those case studies have come from. So the one we did last week actually is coming from our echo series. Today's is also from our echo series. And then last but not least, before Dr. Gloff gets started, is what are the resources that are there for the patients? I think one of the most important ones to share with you is our 24/7 helpline. If there's any number to have, it is that number. And it's 800-272-3900, 24/7, licensed clinical social workers, mental health counselors, and certified dementia care practitioners. So if you have patients that you receive calls frequently from caregivers, and especially around difficult behavior, because we know as the night goes on, some may be dealing and exhibiting more behaviors, they can call them and have support in de-escalating situations. Local resources we provide right now, online education, as well as our support groups are not meeting in person yet. So I say yet because that is coming. Now as we are getting vaccinating and we're giving the green light to start doing those meetings. But we have education that starts with really around lifestyle management all the way through the disease process with our caregiver colleges. And then the other that's on here is our community resource finder. This is a really great tool for your staff to know about as well. But this is also a tool that our 24/7 helpline will use. So although we're a national organization, we do work on a local level. So if they reach out to our national helpline and we identify a need in a local level, it is then referred on to our local program manager here in the state of Florida, and they reach out to the families. So it becomes an extension of your care. And so I think it's really important for you to know about that 24/7. Keep it in your phone, give that to people. That is a really helpful and useful tool, whether it's early in diagnosis or even after somebody has passed away, for grief and supportive counseling. So that therapeutic intervention is available. That is what I had for you today. And again, these resources will come to you by way of email and links. I'm going to go ahead and stop sharing my screen. And Dr. Gloff, I'm going to turn it over to you.
Great, thanks so much. It's a great review there. Certainly some information I actually will probably take some out of my lecture and try to make up some time for the things that you just covered. We do want to talk a little bit about the information once it arrives to you after you've done that preliminary workup that we talked about last week, and what you do with the information once it does arrive to you. So hopefully everybody can see my screen now. If you can't, just send me a text. In essence, what we want to do is recognize that last week we talked about getting the information. We're really focusing on those reversible dementias. And so once you get your data back after we sent out the blood work, you want to know whether or not you're dealing with something that can be treated and is going to be curable, rather than what we usually see with Alzheimer's and other non-reversible dementias, which is really a palliative care approach. So we're looking at things like hypothyroidism, NPH, medication inducement, angiomas, infection, things like that, things that can be cured. Once you get the information back on your CBC, your complete metabolic profile, the thyroid testing, if B12 is on the borderline, less than 12, you expect to, less than 500, you expect to see an increase in MMA, so methylmalonic acid, if indeed B12 is the etiology. I just had a patient this week who had a B12 that was in the 200s. It was listed as being normal, but then we got the methylmalonic acid level back, and it was well over 500, indicating that that person was indeed B12 deficient. And so that person will get treated with B12 on the memory care unit. A lot of times that doesn't lead to a tremendous amount of improvement in cognitive function when you treat that, but it does stabilize the individual and reduce decline subsequent to initiating the B12 treatment. And then there are other selective tests that you may have gotten, and we talked about that last week. In terms of normal pressure hydrocephalus, if indeed you do get either an MRI back that is elevated, or you've pursued the spinal tap and seen that the patient has improved after you've done that, or you've gotten a ventriculogram that continues to light up after 48 hours, then we're talking about treatment for normal pressure hydrocephalus. That means you've got to get a neurosurgeon involved and put a shunt in, and that's generally a ventriculoperitoneal shunt. So that'll go back into the back portion of the skull. It radiates down through a tube that goes behind the ear and right into the peritoneal cavity. It's relatively easy for them to do that, but you want a team that does that a lot. And so if you don't have a team that's local, that oftentimes means that you're going to have to send somebody out to get that process done. It's important to talk to the family about that, because it is oftentimes completely reversible and can make these folks normal again. In terms of what we're doing with the evaluation, you are going to have a lot of times where you get information back and it is not going to be a reversible cause. That unquestionably is going to be the majority of cases. In those circumstances, you may look at the issue of mild cognitive impairment. A lot of times mild cognitive impairment is really just a precursor to one of the other neurodegenerative disorders. And so most people with MCI eventually are going to get to the point where they're going to have a frank diagnosis of one of the other dementias. What is very important is using that term mild cognitive impairment for folks, because that is a term that helps them ease into the issue that there are cognitive issues out there. It is not as daunting as saying up front, that they have an irreversible dementia, certainly the term Alzheimer's disease. And so we want to talk about that a little bit. In the rest of the lecture, we'll talk about how to handle these irreversible cases and what therapeutic options we have that are available. So this is the diagnostic criteria that you have in terms of dementia. It's important that you recognize that it involves all domains. So complex attention, executive function, learning and memory, language, perceptual motor skills, and social cognition are all part of that. And we expect to see a decline certainly in one of these initially, but ultimately these irreversible dementias will involve all of them if the person survives long enough. It is really important that we recognize that a lot of the information about somebody's neurocognitive decline comes from family members or some other individual who's worked with the patient. And so when you get that information, that is something that you use to recognize that that's going to be part of the criteria that are involved in making that diagnosis. Certainly, you may have some diagnoses that arrive through neuropsych testing. Now, that is, if you get a neuropsych test, as we talked about last week, it's a 2 or 3 hour battery test. That time, if that comes back to you and that is positive, and you see significant deficits in that detailed testing, you will have that as a baseline, and you'll be able to continue to use that in terms of the diagnosis and work with the family related to that. Certainly, as things progress, IADLs decline initially, but as time goes on, ADLs will become involved as well. It is important to recognize that when you get this diagnosis, it can't be due to some other disease process. So you have to exclude things like delirium, whether it's through the CAM or other screening tools that you're going to use. And you have to make sure that there's not another psychiatric disorder involved. Keep in mind that there are lots of folks that have psychiatric disorders that will develop dementia. And so you have to recognize that as well, and recognize that the changes are not associated with the underlying psychiatric diagnosis. Finally, you would like to specify what type of dementia it is, and I'll talk about that a little bit. But once you have the deficits identified, you'll be able to at least put things in a category that is more likely to be one versus the other. But ultimately, keep in mind that most of these dementias, if they're irreversible, the treatment is relatively the same, and the cognitive support that has to take place from the caregivers and to the caregivers is also a major part of your intervention and your next steps once you make that diagnosis. So let's talk a little bit more about the first thing that has to take place. Once you have the diagnosis, you have to have the discussion. And so that portion is really important. It is no different in many aspects than telling somebody that they have cancer. And so when you're dealing with somebody who has dementia, and you've come back with the criteria that tell you they have dementia, you have to sit down not only with the patient, because keep in mind, depending on where they are, they may not remember a lot of this conversation, but also with the caregivers, particularly the family, if they're involved in the caregiving process. The compassionate portion of this conversation, recognizing that there are a lot of people who fear dementia more than they fear cancer, more than they fear dying itself. And so having the discussion and being prepared to tell them about the support systems that are out there, whether it's the things that Deanne just talked about, or whether we talk about other things that I'll bring up during the course of this lecture, it is important to let the family members, the caregivers know that they're not alone in this, that this is something where they are going to be able to have clinical support, and that there are other contacts that they can have to help them through this process. Most people will want to know about the risk. Family members in particular want to know, gee, if mom or dad has gotten this diagnosis, are we going to get it also? And so being able to have the conversation in terms of the genetic component, making sure that they recognize that just because mom or dad got it doesn't mean that they are going to get it. And while there is vigilance that may be involved later on, oftentimes this is going to be a discussion. It is more comforting to them knowing that there is certainly a possibility that they won't be affected by this. Certainly, there are also going to be questions about the trajectory. How long is it going to take, or how much time does mom or dad or aunt or uncle or whoever have? And so you want to have some sense in terms of the type of dementia that the individual has, because it does have some bearing on the projection in terms of their survival. So very common diseases like the Alzheimer's, depending on how early you get the diagnosis, you may have somebody who's with you for 10 or 15 years with that diagnosis. On the other hand, if you get them much further along in the process, it'll be a considerably shorter period of time. There are other types of dementias. I had a patient just last week that we completed a diagnosis with progressive supranuclear bulbar palsy. And that type of dementia is something that can be a little different depending on the subtypes even. So you may have somebody who has a 7 or 8 year prognosis versus somebody who has maybe the subtype where they have even a shorter period of time, 3 or 4 years in terms of their trajectory. So it is important to recognize the type of dementia. And so we'll talk a little bit more about that, but be prepared to answer those kinds of questions. It is also okay to say, we don't know at this point. For some of these dementias, it's unclear just how far along the individual is. And so putting a range out there is certainly something that is acceptable. And what I do with a lot of my patients is I tell them, I'm here, we have one point in time, we're going to reevaluate in 6 months. And based on that, I'll have a better idea about how quickly this is progressing in this particular patient, and recognizing that everybody is an individual, that there is some variability in terms of the trajectory for folks when they get this diagnosis. And so that's perfectly acceptable to the family, bringing them back in 6 months and then giving them a better idea in terms of the projections for an individual's not only survival overall, but also functional survival. Are they going to be able to continue to live in assisted living? Are they going to continue to be able to live in their home for a period of time? What do we have to evaluate in terms of them being of danger to themselves or other people? Certainly, you don't want to get that emergency call from the police at 2 o'clock in the morning that says your patient is out wandering down the street naked. I mean, that's certainly a crisis situation, and you want to avoid those kinds of circumstances, and preparing the family for changes and recognizing those flags, if you will, that it's time to bring somebody in or to arrange for 24-hour supervision. Certainly educating the patient and the family is important in this process. That involves some degree of counseling as well as the support that we talked about before. And I'll give you some resources in a little bit where caregivers or family can read a little bit more or go online to get some more information. Certainly that preview that you had before I started gives you some resources through the Alzheimer's Association. Those are all wonderful resources, but there are other resources as well. And then certainly you want to think about an individual in terms of advanced care planning. Ideally, if you get somebody who continues to have capacity, even if you've identified some deficits, if you know that things are going to progress, you want to get those folks involved in advanced directives as soon as possible and getting as many things sorted out with their consent and informed decision-making processes while they have the capacity to do that. And then finally, I want to emphasize how important spirituality is for a lot of your patients, and recognize that if they are spiritual people, that you want to incorporate that in terms of your care plan. And it is perfectly okay to sit with a family, and if they are spiritual and they want to pray with them. And as caregivers, I think sometimes we overlook that aspect of care. And indeed, we've got lots of data to tell us that we as providers oftentimes do overlook that aspect, but it is very important to the patients as well. There are some modifiable risk factors, but these are not going to be curative. So making sure that folks are not vitamin D deficient, looking at hearing loss, and making sure that sensory input from hearing and vision, both of those turn out to be very important, and there are good data for that. Exercise, physical exercise also, in terms of slowing down progression and optimizing function, becomes very important. The genetic components may be out there. Right now, those are not modifiable, despite all the things we see about CRISPR and things that are out there in terms of genetic interventions. Right now, we don't even know what genes to target. And so that's not an issue or something that's an option for us now, but keep an eye on this. I think in the next decade, we may actually have some genetic markers that get identified, and maybe even some ways to modify that to some degree. All right, let's talk a little bit more specifically about treatment that's out there. Certainly, there are some medications that have been approved. In addition to that, there are symptoms that can be managed, and some of these symptoms through behavioral therapy. We've got a lot of really good psychologists here that help us with those kinds of things. Take advantage of the psychology and behavioral therapists that you have available in your area. They will spend much more time with patients than you often have, and it is very valuable to the family and to the patients to go through that process. They're also very good about one-on-one education with the caregivers in terms of managing disruptive behaviors without medication. And so you want to take advantage of that very early on if you can. In terms of health status overall, certainly other illnesses, you want to stay on top of those and manage those as much as possible. And then there are lots of treatments that we have for chronic conditions, and at some point you'll want to reevaluate. Do I need to continue to use that bisphosphonate for osteoporosis when the individual is down to the last year of life? Is that something that's more difficult to administer than the benefit they're going to get? Same thing may apply to cholesterol medications and things like that that we have on board. Even sometimes hypertensive medications may not be worth providing, especially if they start to have progressive disease where it's difficult to administer the pills, or it's difficult for the patient even to swallow the pills. So reevaluate those medications and not only think about what can we do for the underlying disease process, but also what medications can we discontinue for chronic conditions that really are not going to be beneficial on the short run, especially if we get to a point where somebody's got only a year or two to live. That concept in terms of educating the patient and family, I'll talk a little bit more about that. And I've also mentioned advanced care planning, and I'll talk more about that in just a minute. So this is a study because most of us think about using acetylcholinesterase inhibitors. This takes a look at galantamine, one of the agents out there. What I want to emphasize is this scale over here in terms of the ADAS-Cog is a 70-point scale. You'll note that it's presented with only about 8 points on that scale, plus or minus for each direction. And you can see there's very little difference in terms of the impact of the medication. That is true for most acetylcholinesterase inhibitors. So statistically, yes, it's significant. It'll get you through the FDA. How clinically significant it is really is based on the family or the caregiver's perception of whether there's been improvement. And so you want to communicate early on to see whether or not they've noticed an improvement if you're going to start one of these medications. And if you decide to stop, work with them when you're going to stop to see whether or not they notice any real difference in terms of the behavior or the cognitive function. Here's one that looks at ribastigmine. It's a similar kind. You see similar scale over here. Very little improvement, And you can see the benefit of stopping and then resuming. And you can see that in these circumstances with this, there really is a decline that continues, and it's going to continue even if you continue these drugs. And so the bottom line is that you're going to work with these folks, and while you may get some initial stabilization, all of them end up declining again. And it is a relatively small improvement that you see in cognitive function. So really evaluate whether these drugs are going to be helpful, recognizing they also have side effects, including cost, which is an issue that is going to be of importance for a lot of our patients, especially in the federally qualified health centers. One of the things, if you get a patient who's already on some of these medications, a lot of times you'll see that they're on not only acetylcholinesterase inhibitor, but on a memantine as well. And there are some drugs that have been approved that are a combination of these two types of agents. The reality of it is the data are pretty clear that if you take away one of the two, there really isn't a detectable change. And that has pretty much held up in terms of statistical changes as well. So in this circumstance, getting rid of one of these drugs usually saves cost, and there's no question about that benefit. But a lot of times the combination really hasn't added anything to the regimen. And when you stop one, there's really no change that's detectable. And in fact, this is a review that took place in January of 2018, a meta-analysis of 140 plus studies looking at any combination of donepezil, ribastigmine, galantamine, and memantine. And basically what it showed is there are lots of side effects that occur without a lot of benefit. And so in general, when you're looking at these drugs, it really is okay to discontinue these drugs and follow the patients. And certainly if you start seeing some of the side effects like nausea, diarrhea, vomiting, certainly increased headaches, and urinary changes. Bladder capacity oftentimes changes when you use these drugs. They are acetylcholinesterase inhibitors. And so for a lot of folks where you have bladder issues, this may be a drug you want to stop as well for those reasons. So lots of concerns about using these drugs and lots of reasons to discontinue them if you're not really seeing a clear benefit, and reevaluate over time to see if that benefit continues. There are lots of non-pharmacologic behaviors out there. Your behavioral therapist will work really well with these. We do a lot of reminiscent therapy on the memory units. Sensory stimulation is really helpful. We do a lot of aromatherapy, not so much the acupuncture in our memory unit, but certainly things like animal-assisted therapy. Music therapy is marvelous. Tremendous amount of studies out there now. I've got some older studies that I've listed here at the bottom of this slide, but new studies are coming out all the time to show benefits, particularly not necessarily globally for everybody who has it, but there are clearly some individuals who respond really well to some of these interventions where others may not. And music therapy is certainly one of those where you can see dramatic changes in behavior in people who get music therapy. Certainly the education in terms of the caregivers is important. I'll talk a little bit more about that, and I'll give you some websites that you can use. Lifestyle factors in terms of nutrition, meditation, exercise. And you might think, oh, well, they're demented, they can't participate in meditation. That's not true. They can do that. You can do a lot of behavioral relaxation techniques with these folks, and they do really well with them. So it's important to get behavioral therapy involved and getting them into programs, particularly where you have daycare centers in the area. There are a lot of daycare centers that are out there that really focus on people that have memory issues. Certainly some of the memory units themselves offer programs where they'll allow people to come in from the community, and they'll be able to participate in programs during the day and take advantage of the activity coordinator programs and things like that. As I mentioned earlier, advanced directives are a big deal. Getting folks involved early on in the process, making sure that caregivers who have been assigned to be the healthcare agent or the proxy, that they're involved in that process early on, hopefully before you really lose cognitive capacity, to make sure everybody's got a plan in place and that we adhere to the plans and the wishes of the individual who had put them in place. Palliative care, as an individual goes further along, particularly as they lose functional capacity, and I'll talk about criteria associated with that, but palliative care or even hospice care in the last 6 months is something that you definitely want to consider. And very many of the hospice organizations have started to embrace this, and it's very helpful for a lot of patients, particularly at end stage. So in terms of end stage dementia, what mostly will be evaluated, particularly for hospice, will be that the individual is no longer able to walk independently. If they lose intelligible speech, that's something that is a hallmark of having less than 6 months. A decline in oral intake, and certainly if they have a 10% loss in body weight over the course of a 6-month period of time, that's usually a flag that we use in hospice to determine if they're eligible. And even if they're making multiple visits to the ER or they've had multiple hospital admissions, certainly if they are using a Foley or an NG tube, a lot of times these can be discontinued in individuals at the end of life, although we may have a Foley in place because it's palliative in nature. And so that sometimes can be appropriate for individuals who become bedbound. Some of the additional sites that you have available, you've already heard about the Alzheimer's Association, so I won't talk about that. But in terms of behavioral issues, there's also a UCLA site that's out there. This is a grant-funded site. It's really a marvelous site for caregivers who are dealing with behavioral disturbances. They can go online and learn about how to manage folks who have dementia. A lot of times the caregivers have never dealt with anybody with dementia. And you'll hear comments like, oh, mom is manipulating us, or she's doing this on purpose. Well, of course, if she was able to do that, she wouldn't have the diagnosis of dementia. So these are things that are really helpful for family members to go through that and have an appreciation that these kinds of behaviors are not Machiavellian in any sense of the word. And they really are things that are related to the diagnosis and how the family members can work to redirect individuals to help them in terms of better control in terms of mood and anxiety and things like that that can precipitate and escalate, and how to reduce that and de-escalate potentially problematic behaviors. So in summary, we've talked a little bit about what to do with the data once you get it back, how to present it to the families, talking about the irreversible nature. If you've gotten one that's irreversible, obviously, if you're fortunate enough to have something that's reversible, you will treat that. But in terms of the irreversible ones, the therapeutic options that are out there, really the best ones are not pharmacologic right now. And looking at the behavioral management, the caregiver support systems that are out there. With telemedicine, we have done a much better job in terms of caregivers because they really can't get out to group therapy sessions. They can't get out to the group meetings. And when you do a Zoom meeting and you've got a lot of people who get online for maybe a half an hour and have that sort of cooperative intervention through Zoom, that actually has been a positive thing that we've learned from the COVID-19 experience. And so that is something that can give support to caregivers, and they can exchange information through that modality as well. Next week, we'll talk a little bit more about research. Dan talked about a little bit about that in terms of the ECHO programs and things like that that are available. There are opportunities out there, and I want to talk a little bit more about that. And so next week, I'll talk a little bit about refractory behavior and things that you as a clinician can do related to individuals that present sort of as a problem, if you will, once that diagnosis takes place, and how to interact with individuals with particular types of behavioral problems. And then we'll talk a little bit more about the research opportunities that are out there. Because we started a little late, we're finishing a little later, so I think I'm going to end things right here, but I do want to open it up for questions if anybody has a question or something they want to address right at the end here.
Doris, was this helpful? It was very helpful, Dr. Gloss.
Mm-hmm. It was for me, absolutely. Those conversations can be hard, so it really, this was a very simple breakdown, because sometimes it looks kind of overwhelming, but this was perfect to kind of make it simple for the family, and next step and next step and next step. So I think this is a great breakdown. I have to go, y'all.